All right. So next up, integumentary and basic wound care. I was trying to look through the textbook. It might not be this textbook. It might be our textbook from next semester for phys agents. I hope to teach you a foundation you can work on. None of the information I will teach you will be enough to go and treat wounds. It should be enough to pass any licensure exam. It should be enough to have a foundation knowledge where if you're really interested in treating wounds, it gives you a foundation to learn a lot more from it. So make sure that you just understand the purpose and why we're covering this stuff, and that we are being very short on the amount of information, because we could spend years just talking about wounds and wound care and how do we make them better. In one of the textbooks, it says specifically, we will talk about this briefly, but likely the PTA would likely need expanded training beyond the scope of this textbook, right? So it makes sure we just understand. All right, functions of the integumentary system. Obviously, protection for physical and chemical invaders, sensation, thermal regulation, excretion of sweat, vitamin D synthesis, really important. But the big thing our patients are probably going to ask us about is the cosmetic look. For our techs, when the patient has surgery, what is one of the first questions they always ask? Is it going to scar? Right? So the cosmetic piece is something that we really have to understand. And if we do a really good job healing these wounds, those scarrings can be minimal. Quick overview, you have 3 layers of the skin: epidermis, outermost layer, mostly dead skin cells, avascular layer, the dermis, thickest layer, includes all of it's very vascular, a great deal of moisture, very pliable, houses all of the appendages. And then the subcutaneous tissue, also known as the hypodermis, innermost layer contains adipose tissue, fascia, lymph, some sensory structures, highly vascular as well. Hopefully that's all review. So wounds can come from many different sources: insect bites, pressure wounds. We've talked about a little bit already. Surgical wounds. Every single one of us is going to see surgical wounds at some point in our career. Even my wife, who works in the school system, the kids she's working with have surgeries. They have muscle lengthening procedures. Her job is to make sure the kid can function in the school. She has to be aware and monitor wounds even there. So all of us will see it at some point. Vascular compromise is another thing we are going to spend a lot of time on today, because most of our patients are also going to have sort of vascular compromise. So it's our job to protect the wound. So hand hygiene and PPE is some of the steps we already learned to protect that wound. And in some instances, we're going to be asked to promote healing and be involved in that wound care process. Important for us to identify the type of wound, phase of healing, and have basic understanding of positioning and treatment to help promote that healing. To 1, not make it worse; 2, hopefully make it better. Basic goals: protect the wound and surrounding tissue for additional trauma. Provide optimal environment for healing. Reduce strain on tissues near the wound. So we had asked quickly last time when we were going through our skin screen, we talked about turgor test. Who asked me about turgor testing near the wound, right? So that's one thing, would be avoiding the stress around the wound for that. Protecting the tissue in the area from mechanical stress or movement, reducing the number of microorganisms in and around the wound, and decrease the formation of scar tissue. Those are our basic goals. So one thing that we always have to understand is, as PTs and PTAs, we see more of our patient's skin than most other healthcare providers. How many of us have went to our yearly exam, a yearly physical with a doc, and they don't do a skin screen? They don't have us remove clothing and give a up and down look. Does that happen? Yes, I've seen a lot of head nods, right? If your doc does it, then great. got a thorough doc, right? But it's an easy thing to skip. But for us, when we're assessing somebody's scapula, what is the problem here? What do we like to do? Visualize it if we can, right? So remove as much clothing as we can just to see it's musculoskeletal problem, just to see it. Next semester, when we talk about modalities, we should be screening the skin to make sure the skin can tolerate whatever modality we're about to place on it. So it's the first step of applying any modality is screen the skin. I don't care where if you're working on glutes, you're going to put a hot pack on the glutes. Guess what? You got to do the skin. Screen it, make sure there's no other problem, because all it takes is a small wound. Now we're adding a moisture and environment to it. Now with what we know about wounds, we've just created an environment that some sort of pathogen can grow. So we are going to be seeing so much more of our patient's skin than what most other medical professions will see. So we have an opportunity to catch wounds earlier on, screen for other conditions like skin cancers, and to educate our patients on the protection of their skin, which is going to be crucial for patients with diabetes, most of all. A lot of other patients, but that's the biggest patient population that's going to have problems with this. So screening the skin, we've already talked about it. What was the mnemonic that I had for screening? C triple T me. So I will ask you, if you guys ever come across some sort of studying method that works for you, please let me know. I taught skin screening for years, and someone always messed it up. Actually, a lot of people would forget one of the things. I taught it in a slightly different order. I had one student say, I asked, "Oh, how do you screen the skin?" And then she just blurted out, "C triple T me." And no one has ever gotten a question wrong about skin screening since that student told me, no, I just rearranged the orders of it. I just remember it when I say C triple T me. No one's ever gotten a question wrong since that one student told me that. So I started switching the order of the way I teach it to match that. If you have something that works for you, please let me know, because it helps all of your classmates. And I mean, this was 6 years ago. So I've taught 6 years of PTA students that have never gotten a skin screen question wrong since, because of that one student. So share if you can. All right, so C triple T me, the broad rules are skin should be uniform, proximal, distal, right versus left. If there's an area that's abnormal, like that's a warning sign. Okay, think about this a little bit more. So the first step, color. We have a couple of conditions that we will look at. Hemosiderin staining, one of them. This isn't going to work for here, but that's okay. So hemosiderin staining is just a darkening, a kind of brownish, rusty looking darkening of the skin. That's from just blood pooling, and the iron containing pigment in the blood is just staining the skin. That's all that is. Most often due to venous insufficiency. Okay, let's wrap our heads around these words. Venous insufficiency. What's wrong now? Not enough blood flow to the area, right? I'm sorry. I said something wrong. Not enough blood flow is good, but what do the veins do? Get blood to return, so moving away from the extremity towards the heart. So if the veins are a problem, what's happening to the blood? It's pooling. If it's pooling, the iron-containing pigment is sitting next to the skin, can stain the skin. That's what's happening. All right. There's a few ways we're going to look at the difference between venous and arterial insufficiency in a little while. But venous insufficiency means the veins don't work well. We have cyanosis. I didn't get a picture of that. But that's what Jack's lips looked like before Rose let him go. That's what all of our lips look like in the first couple of weeks we were here, right? That's that bluish tint of lips, face, fingers. When we see it, it's reflexive. I'm cold and now I'm blue. It could also be a sign for more serious lung disease. or we could also have Raynaud's disease. So there's a few different pictures here. Raynaud's disease is hyperreflexive reaction to cold. It's a nervous system kind of trigger. It's not well understood. Anybody here have Raynaud's? Any of these pictures look similar to you? What happens to you?
Big toe specifically.
Okay. White. So you're look a little bit more like kind of this hand here, where it's just two fingers turns white. Some others it's fingertips. You can see like this picture is the distal half of the all fingers. So okay, yep. So I'll tell you ahead of time when we do cold and PTA2, you don't have to have cold put on you. So protect yourself, okay? But that's also the thought process. If our patient's got a lot of swelling, but in their chart we also read Raynaud's disease. All right, well, I'm not going to use cold to treat this swelling, even though I think it'd be great. I don't want to trigger their Raynaud's. Is yours painful?
No, it's numbing.
Numbing. When the blood flow returns, does it hurt when it returns?
It depends how long I've been numb.
Okay. Okay, tingling burn. Some people it's a really discomforting sensation. Some people it's painful. So anyway, that's Raynaud's. We also have jaundice. There's a picture of twins. One has a liver disease, the other does not. So that's the yellowing of the skin. And eyes are, this is really severe yellowing of the skin. Most of the time it's the eyes you can see the best. And the last thing is arrhythmia. Arrhythmia we've all seen. Anybody get an insect bite? Anybody get a mosquito bite? That's what happens after that. You hit that away, then what happens? Turns a little reddish, right? So arrhythmia just means increased blood flow. Sometimes that's going to be a good thing. Other times it's going to be a problem. But it could be because of infection, inflammation. The normal inflammation cycle is fine. Allergic reaction, could be radiation. Remember, the skin should be blanchable, which means when we press on it, we're squeezing the blood out of the capillaries. It should turn pale, and then it should return to color, its normal color. Non-blanchable skin means what? Stage 1, what? Pressure injury. Nice, you guys did a good job. The whole drive this morning, I kept reciting pressure injury. And I thought I was going to get it wrong, and you guys got it right. Look at this. All right, so the next up, temperature. Temperature change due to blood flow should be not higher or lower in one area. If it's higher, our first thought is what? Broadly speaking, we're concerned with infection, but take a step back. It's not always infection. It just means what? I would think it just means increased blood flow. If it's a problem or not, we got to start figuring it out, right? So the first step is it uniform? No, it's not uniform. It's higher. Okay. Is that okay for what I want, right? That's the next thing. It's almost like a precaution. It's like yes or no. Okay, it's good. Nope, it's uniform. Great, don't have to worry. Oh, no, it's not. All right, think about this. Is there a brewing problem here, or is that normal for this healing process? Texture, quality of skin, is it smooth or rough? Hyperthyroidism cause soft skin. Hypothyroidism will cause rough skin. Turgor is that basic hydration test. Now that we don't, I think you guys didn't have gloves when I was wearing gloves and you guys didn't. So that's the test. You gather some skin. We don't pinch, we gather, right? So we gather skin, let it go. If it recoils within 3 seconds, right? That's the basic hydration test. If it stays puckered up, that's a sign of dehydration. Moisture, skin should be slightly moist. Arterial insufficiency can lead to chronic dry skin. Arterial insufficiency means what? Blood flow out from the heart to the rest of the body. Why would that cause dry skin? Not getting blood flow to the skin. Blood flow also contains all moisture and water and other nutrients. So yes. While data collections, that's what we do with all of our tests. Data collect. That's we're collecting the data. So data collections and exams that go with it can lead to hyperhidrosis, skin that's excessively moist. And then edema and effusion. We didn't cover earlier. I couldn't change that. A few different ways to measure edema. We'll talk more later about that, but with everything we do, we'd like to measure. There's different ways we can measure: tape measures, dunking in water, looking at water displacement. We will cover that later. So let's pause real quick. Do one upper extremity and one lower extremity skin screen. Just get 2 quick reps skin screen. C triple T me, work your way through it. Do it out loud, because here's what's always going to be helpful, both in this room, but I also think this is universal for our patients. If we're looking at it, can I borrow you? So if we're looking at our patient and we're just doing this versus, all right, Abby, I'm going to be looking at your skin. First thing I'm going to be screening for is color. Should be uniform, proximal to distal, right versus left. Not seeing a little color abnormality there. You get a little scratch of that earlier. No problem with that. Okay. Next step, temperature. I'm going to feel temperature, proximal, then distal, right versus left. Making sure everything's uniform. Turgor, let me gather some skin. Which one is better for our patient? Second, because we're telling them the information. We're not just going, all right. Or we're not just gazing at their hands, like, without telling our patients what we're doing. All right. So talk about the steps out loud each time. Okay. So 2 skin screens, 1 upper, 1 lower. Feel free to do different partners. Guys, once we learn the C triple T me, it's a low rep activity. All right, so the next things we'll talk about is just the phases of wound healing. So we have 3 major phases: inflammatory phase, that's going to initiate the wound healing; proliferative phase, which forms new tissue; and then the remodeling phase, which is going to reorganize all of those new fibers, that new tissue. And I think if you can think of the last time you had a cut of some kind, all of these phases existed. So think of that stuff. And then when we go and apply this to our patients, realize that our patients have wounds that are either larger or their healing process is a lot slower for a lot of other reasons. But think of the last time you had a cut as we learn these things, and it'll start to make a little bit more sense. So the inflammatory phase initiates the wound healing, creates the clotting cascade to stop additional blood loss. It begins immediately after trauma. Phase between 1 and 10 would be considered the inflammatory phase. Function is to limit further tissue damage, remove injured or damaged cells, and then to begin repairing injured tissue. 3 stages within this phase. The vascular stage, increase blood flow to the tissue, which is going to, why do we increase blood flow? Why do you think? Well, not like why did you do that? Like, this just happens. We don't think about it. To promote healing, to bring all the good things that's within our blood to the injured area. White blood cells, platelets, all other, all healing elements are going to go there. It will produce edema, arrhythmia, warmth, and potentially some discomfort. We would then also look at the exudate. Exudate is the discharge. Several appearances it could be. Most common, serous, watery, pale, yellow, clear. Might have a speck of blood in it that tints it a little pink, but nothing, mostly water. It could be purulent, pus related. A little different now. fibrinous, which is all the clotting factors to it, or hemorrhagic, which is bleeding. And then the other stage is reparative stage. The damaged cells are replaced, healing actually begins. Now, next phase is the proliferative phase. There are overlaps between phases. It's not just, okay, stage 1, you're done. Stage 2, start right now. Like there's an overlap between it. So this is the formation of new tissue. Days roughly 3 to 21. New connective tissue forms around the wound called granulation tissue. If you've seen a bunch of wounds, you could say, oh, that's granulation tissue. I'm not quite there yet. Angiogenesis is a lot of fun. That's new blood supply establishes. We're growing new little capillary buds. That's fun. Wound starts to contract. Then we also have epithelialization of wound tissue. Epithelial cells migrate upwards to heal the wound. They look light pink, pearl-like appearance. So again, someone that's really good at looking at wounds and know what the tissues look like. That's granulation tissue. That's epithelial. This stuff is healing. We're happy. Like it's great. And then the last phase is the remodeling, also known as maturation phase. That's the fiber reorganization and shrinks the scar. Days roughly 21 up to 2 years. Anybody have a surgical wound? Take a long, long time to actually get back, right? Those well, it's still there, but it's at this point it's been over 2 years, right? So, but it takes a long, long time for that tissue to return to its normal state. Reorganize the collagen tissue into a more definitive finite pattern. Newly repaired tissue has roughly 15% of the pre-injury tensile strength. That's the ability to withstand that, not quite distraction, that's an imperfect word, but that pulling apart stress. Will reach to greater than over 80% over time. But what is scary, and I've started seeing this more and more. I used to never see this. I started seeing this more and more. For our knee replacements, I heard of one person this has happened to. Not a lot of pain, having great initial healing, wanted to really work on his knee bending. PT, PTA, and techs weren't paying attention when he came in. Right guy walks in. You guys know who I'm talking about. Like the guy who just walks in, he's gonna make the pot of coffee if it's empty. Like he's just part of the omnipresent guy around the clinic, right? You guys know what I'm talking about, right? Oh, Larry's here, right? It's cheers. Hey, Norm, right? So, hey guys, hey Larry, how's the knee? Great today. He starts hopping on the bike because that's how it always starts. He thinks to himself, I'm gonna drop the seat height. I'm gonna work on this knee bend. I'm gonna work on it hard today. Went, bit the bullet, went through the pain, split open his incision. Whose fault is it? First of all, every single person that was involved in the case. Now it ultimately falls into the PT, and if he was on your schedule that day, it's on you. It's not on me. But I think every single person had a spot to play with that. But you look at him that day, walking great, minimal pain, guy who wants to get better. You look at the skin, you say, this is healing great. Like there's no warning signs. Just went too aggressive because that pre-injury tensile strength is just not there yet. So we have to educate our patients. Listen, for at least the first 3 weeks, we are going to be really careful with this. I've started seeing restrictions, and I used to never see this. The last few knee replacements that I saw, in the restrictions, it says do not flex past 90 degrees for the first 2 weeks. I used to never see that. Now I'm seeing it because apparently that guy wasn't the only one. So that's really important because you look at the incision, all the steri-shoots fell off. It looks great, looks healing, looks beautiful. Still, remember, it's very weak still. So 2 processes for wound healing. First one, or first or primary, I refer to this as primary intention. Edges of the wounds are approximated by sutures, steri-strips, staples, glue, other mean. I don't see a lot of staples anymore. Rarely do I say. Have you guys been texted? Have you guys ever seen staples for a surgical wound? Mostly sutures. I'm seeing a lot more glue lately, which is pretty cool. But definitely the steri-strips. You see a bunch of those, right? So that's fine. We're getting the edge of the wound, we're getting them right next to one another, and we're trying to stick them in place so the edge of the wound, they're right next door to one another. Secondary or second intention, the wounds are too far apart. I can't stretch the skin, either too much skin has been lost, like the edges are, the gap is too wide. We can't get them next to one another. Larger surface area, retracted wound edges, large amount of tissue has been lost. It's just not going to happen. So that has a much lower healing rate, more risk for skin infection because we're not closing that wound as fast as possible. It takes a long, long time. Much more likely to scar. For a lot of these, we're going to be using surgical skin grafts, flaps type techniques because we want to cover the wound with skin to protect it from infection as fast as possible. Not all. I shouldn't, maybe preferred might be a strong word right there, but that is an option. I think we've all had both of these at some point in our lives. I know my kids have. My kids have had small cuts, learning how to use a knife, paper cuts, right? They've also had these second, fell off their bike, just had a big, that road rash on their leg, right? It's just put a band-aid on this, but the wound edges, like, no, you just scraped off the whole surface. It's not nothing to put together. As we are looking at these timelines and stages, when you think of your own wounds that you've had, does this make sense for what you've gone through? Right, and sometimes it's really quick, other times it takes longer, but that's the process that goes along. And that wound maturation is just wounds healed, got a little scab, and that scab is going to form into the regular skin tissue that we've got. Other factors that affect wound healing: intrinsic factors, health status, what are your disease status is, what's your circulation like, do you have diabetes, what's your age, body build, nutrition status, all of that matters. Extrinsic, did we relieve all of the mechanical stress or not? Is there additional debris in there that we're always going to have to be cleaning out? Is that a big problem? Temperature, laceration of skin, infection, chemical stress, medications, smoking, alcohol use, radiation therapy. There's a lot of other things that can really limit our ability to heal. Now, looking at these lists, our patients, do you think they have chronic diseases? Do you think they have circulatory issues? Diabetes, ages of all types, but yeah, that can be a factor. Nutritional deficits, nutritional problems. Most Americans, I think, have some sort of nutritional problem. Smoking, alcohol use, drug use. Yep. So there's a lot of other things at play here. So the first thing we're going to talk about are burns. Now, again, in the burn unit of the hospital, PTs and PTAs are the kings and queens of that unit because we have to be seeing these patients to prevent blood clots. We have to be seeing these patients to prevent further decondition. If the burn crosses a joint, we have to be mobilizing that joint so the skin doesn't heal in a contracted spot. While we're in there, might as well do the wound care because of such high risk of infection, and it's so laborious for staff to enter and exit that wound with all the PPE that, hey, while you're in there, go ahead and clean that wound out for me. Here's your stuff you're going to use. Burns, a couple different ways to describe burns can happen when coming into contact with dry heat, fire, moist heat, steam or water, chemicals, electricity, or radiation. Electricity are my favorite type of burns. If you're, because typically with an electrical wound, there's an entrance and an exit wound. So it's pretty fascinating to think like, oh wow, you touched the wire here and it went out there. Like it's what happened? I see the wound here and here. What else happened that I can't see? That's always fun to think about.
He had a head injury
Yeah.
as well because he had a banged head against the wall.
Wow. Wow. Yeah.
I guess that's.
Yeah, I wouldn't think. Like, all right, guys, remember, use your head. If you ever get, yeah. Absolutely. Yeah. Better than holding on.
Yeah.
That guy in Jurassic Park didn't have to do that. He just. So burns are described by the depth of the wound, superficial, also known as first degree. The epidermis is involved. Partial thickness and deep partial thickness are second degree. Now the epidermis and dermis are involved, and full thickness, third degree. Now we're into the hypodermis. And we also to measure is the rule of nines. So the rule of nines describes the percent body surface involved. The body is broken up into segments of 9. So the head and neck are 9. Each upper extremity is 9% apiece. Each lower extremity is 18% apiece. Makes sense. Arms are about double what legs are about double what an arm is. Anterior trunk is 18% and posterior trunk 18%. So it's just a way to just estimate how much body was involved. Now, children do have slightly different percentages. I won't ask you on a test. I will ask you for adults, but not for kids. But just understand, put in the back pocket, slightly different percentages. I think the head is a lot higher percentage-wise than for adults. I think that's off my head. When more than 18% of the body area is involved, or when face, hands, feet, perineum. What's perineum? That word? Undercarriage, right? If you think of if you sit on a bicycle seat, any place that's in contact with the bicycle seat, it's a good way to think of it. All of those areas are considered, if it's 18% or any of those body parts, those are considered major burns. Now, the rule of nines and knowing the degree of burns is important. At one point, the formula for risk of death was what percentage of the body multiplied by what degree equals your risk of death. So if you had 9%, just your arm, but second degree burn, you have an 18% chance of passing away because of that. Now, that formula isn't as good nowadays because we're a lot better at treating wounds. We're a lot better at preventing the infections. We're a lot better at all of the other consequences of having a major burn like that. So I explain it to you because I do think the importance of the rule of nines and knowing the stage is important. And that gives you just some idea of the risk that's involved in, but it's just a stage 1 burn. Yeah, but it's 40% of his body. That's a big problem. So again, that formula I don't think is great nowadays, but it's something that I do think is meaningful. Other integumentary injuries that we will see: incisions, talked about a lot already. Pressure injuries, we've already talked a lot about as well. And then we'll talk about other types of ulcers. We already talked about pressure injuries, risk factors, immobility, lean body mass. We've already talked about all that stuff. Areas of high risk depends on the area that we're, the position that we're in. What are the stages of it? What was my process to get to the right stage? Step one, is it superficial or deep? Okay, if it's superficial, my next question, is it skin intact or not? Then I get to decide if it's a stage 1 or 2. If it's deep, deeper structures exposed, muscle, bone, ligaments, tendons, fascia. If it is, if it's not, great. One little curveball thrown into the mix. What's the curveball? Unstageable. I always think of my favorite Colombian drug lord when I think of this, because what's in the way? Escar. There's a big feral hippopotamus problem in Colombia because of Pablo Escobar's zoo that he had. Now they're just they're just running wild, and I thought he had a bunch of it. I'm not a Escobar historian by any means, but all right. So we learned today about hippopotamuses in Colombia, witch stares. So we'll see what else we can learn. You never know where we're gonna go. So a couple of different vascular conditions. The three major ones we're going to talk about today are venous insufficiency, which means what's not working well? The veins, and the veins' job is to bring blood from where to where? From the extremities to the heart. Okay, so if the veins aren't working well, what's happening? Blood is pooling. Give me a skin screen on somebody who has a venous problem. First thing, color. What do you expect? Darker. Whether it's staining or not, it doesn't matter. It's going to be darker red or rusty brown, but darker. Good. Next T. Temperature. Probably warmer. The blood is staying there longer, warming the skin more. Okay. What's the next T you want to talk about? Texture. What do you think? What is my options? Make it binary. Smooth or rough. Probably on the smooth side, because there's excess hydration, excess, all of that. And I just gave away the answer for the next one. What's the next one? Turgor. Are we going to have a turgor problem or an elasticity problem? No, there's no problem at all. What's the next thing? Moisture. If we have a wound because of it, what do you think? If we have lots of exudate, yeah, yep. And then last one, edema. What do you think? Yeah. Good job. Look at that. Look how much knowledge you guys already have. We haven't even learned about venous insufficiency wounds yet, but because you took anatomy and when you know what a C-triple-T me is, you know all of the answers already, right? Beautiful. Arterial insufficiency, what's the problem? Arteries are the problem, so there's less blood flow from the heart to the extremities. C-triple-T me. Color? Pale, potentially bluish, maybe, but at least pale. T. Cold. T. Rough. Rough skin. T. What next T? Dry. Sorry, the turgor. Less elastic. Good, so probably a positive turgor test. Next thing is M. Moisture. Now we're looking at dry. Edema. No problem. Diabetes have some special things. We'll look at those in a bit. Look how much you guys already know, right? So arterial insufficiency, restricted blood flow to the periphery, mostly because of peripheral artery disease, PAD. Usually it's focal to one area, although it can be a lot of different places as well. Progression of the ulcers can take years. An early warning sign is called intermittent claudication. I bet you if you've been a tech, you've had a patient with this. If you've been a tech for a year or two, we've probably had this. Intermittent claudication is a pain, cramping, or deep ache in the calf brought on by activity, but's resolved from rest. Does that sound similar to any of the patients you've seen? Anybody? No? All right. Walk me through what's happening. So we ask our patient, hey, let's walk on the treadmill, let's ride the bike, let's do this, lunges, whatever it might be. Why is there a deep pain, ache in the calf brought on by activity, but once we rest, it's relieved? What's happening? What's the physiological things that's happening? Exactly. Activity is increasing the demand of blood because blood has all of oxygen and nutrients to it, right? So we're increasing the demand, but the arteries have a problem and the supply can't keep up with the demand. When we talk about tissue in our bodies, if we don't get enough oxygen, what's happening to the tissue? It's going to die. We're building up metabolic waste. We're not clearing the metabolic waste. We're also not delivering the oxygen it needs. Eventually, it will die. Anybody ever work out tough and have that burning sensation? What's that burning sensation? Lactic acid building up because we are exerting completely. We're creating a lot of metabolic waste. We aren't able to clear it at the same rate that we're producing it, which creates that discomfort. Right? So we've experienced this most of the time, right? Once we cease the activity, the pain gets resolved because we reduce the demand. And now the supply to demand can level out. So that's intermittent claudication, early warning sign. Oh, we're at risk for arterial insufficiency wounds down the road. Leg elevation will increase pain. Why is that now? Not getting enough blood flow. So we're not getting enough blood flow as I'm standing here. If you invert me and put my leg up, now my arteries, not only are they already narrow, but now they have to fight gravity. You've added to the problem mix. When we think of arterial insufficiency wounds, think distal. The more distal, the worse, because that's the longest road to get blood supply, right? So we're at risk. Toes is the number one thing. If you read arterial insufficiency wound, or if a question starts talking about patient has a toe wound, you should automatically think, okay, the answer is probably going to be arterial insufficiency wound. As I continue reading this question, my job is to then say, is this the one exception to the rule? Because it's probably arterial insufficiency. If you're talking about toe, it's probably an arterial insufficiency. It can look like a dark blood blister appearance with no mechanism for that, though, right? Blood blisters are like a pinching. Anybody ever have one, right? It's like a pinching thing, pool of blood, skin stays intact. It's that dark area. Joan had a blood blister on her toe, but no mechanism for it. And Joan just sits in the recliner 23 hours a day, so there's little chance of her. It's just a blood blister. Really? No, it actually was an arterial insufficiency wound. It was gangrene. That's what gangrene is. So, here's some pictures of it. Let's see. Here we go. There's some. Right there. You can see. Make sure you guys get the full back. You can see here. I don't know what's going on here. That's no fun. This guy's got a lot of problems. not gonna show up here, is it? Who can do a skin screen for me? Yeah. I don't want anybody. I would say like, I just watch these videos while you're eating dinner or washing dishes. Maybe the dinner part is not the. But if you, so I don't want to spend too much time on this. If you did a skin screen with this guy, C me, does he check all the boxes we just hypothesized just a minute ago? There you go. There's a little excessive. Thanks. Uh-oh. So again, that written exam comes up, whether it's in my class or your licensure exam, if they start talking about wound, they start talking about toes, wound to the toes, your first gut is to say, okay, it's going to be an arterial insufficiency. Let's just make sure there's not a curveball here that I'm supposed to pick the one exception to. Venous insufficiencies now, what is pooling? Typically lower extremities. Why typically lower extremities? Gravity. That's it. Can also be the problem with poor muscle action. So muscle contractions helps feed the blood flow back to the heart. Failing venous valves. So there's valves within the veins, right? So blood gets, as the heart contracts, blood's supposed to be going up, and then a little valve flap shuts in the veins to keep it from falling back down as we're in between heartbeats, and it pops back up, the next valve, and then if that valve fails, then that blood can just kind of slosh up and down, and it rarely makes it back in play. Or an obstructed vein. Blood clot. So the pooling of the blood leads to edema, hypoxia, malnutrition of the tissue, and then leads to breakdown. Most common location, medial third of the lower leg, near or proximal to the medial malleolus. Classic location. I mean, that's it. Venous insufficiency, proximal to the medial malleolus. What's the big veins in the legs? Saphenous. We have two of them. Just one bigger and one smaller. The greater saphenous or the lesser saphenous. Where are the saphenous veins? Medial side, right? Anybody taking that out of me? Skip the vascular part and went right to the muscular. But here we got good veins in the musculoskeletal part. Right. Yeah. So go back to your anatomy textbooks. There we go. So again, medial lower leg, proximal or near medial malleolus. Your first reaction should be, okay, I think this is going to be a venous insufficiency. They're talking about a venous insufficiency. What could be the curveball that I've got to screen out? If my patient just shows up with a wound, maybe it's a little bit more proximal. Ooh, look at that. Maybe it's just a little bit more proximal to medial malleolus. What's the? I have to decide, is it pressure or venous insufficiency? I can do that simply with what test do we already know? Skin screen. So on a question bank, the CTTT if it's a wound near the proximal, near the medial malleolus, and there's other information on that CTTT that's going to lead you one direction or another. We have other tests we'll learn shortly. Now, patients who have this pooling problem, it's really important for us to make sure that they don't have a blood clot. A blood clot is a life-threatening condition. If a piece of that clot breaks off, it's going to travel to the heart. and then to the lungs or to the brain. Then we have a heart, lung, or brain. It's a medical emergency. The way we can do it, and this is not for a test, but this is something you will. I tell you some things that you'll say, I hope they remember this at some point 3 years from now. Hopefully they'll pull that memory out of their way back machine and pull it out. This is something you have to know for your career. This is not something that's maybe you'll need this. No, the Wells clinical prediction rule is the number one test that we have to rule in or out whether a patient might have a blood clot or not. So all it is a list of yes/no questions. If they answer yes, they get a point. With the one exception, last question, alternative diagnosis as likely or greater likelihood than venous thrombosis, blood clot, we get to take away 2 points for that. If they have a 0, good, rest easy. If they've got a 1, time to get to the hospital. Call the doc, see if they want to see the patient directly or send them right to the hospital. So that won't show up on an exam, but you have to know that tool. I had a patient, you guys ever see, what kind of commercials are on daytime TV? There's like 2 categories of commercials. You guys don't watch as much daytime TV as me. It's my patient's home, the TV is always on. I'm watching Maury Povich, soap operas, Price is Right. That Wayne Brady is a talented man. I don't care what anybody says. What kind of commercials are on? Medication commercials and lawyer commercials. I had this one patient. I went to her because she had a fall risk. No other problems. She just had a fall, no other injuries. Josh, I'm really concerned I have a blood clot. Okay, why? Well, on TV, they talk about blood clots all the time. Okay, all right. It's either a lawyer commercial or medication commercial talking about blood clot, and it's probably both of them. Okay. You don't have any sort of injuries that would make me think you have a blood clot, but you know what? Let me pull out this. This is a Wells clinical prediction rule. This is the test that we use to see if you have blood clots. This isn't my feeling or your feeling. Let's just work through this list together. And I sat with her and I just read every single item right with her. And at the end, she's a 0 because she doesn't have anything. And she's, oh, good, I'm so happy. Yeah, great. Using Wells clinical prediction rule just to ease some anxiety. So we should know the signs and symptoms of arterial and venous insufficiency. Location alone is going to help you. That should be maybe not quite 90% of the answer is going to be in the location. If we do C, triple T, and me, it's going to fill in a bunch of other information. Now we've got other testing we could do. We probably don't perform this, but we could. We need to know what it is, and we need to know how to interpret the data when it comes back to us. So we could use the ankle brachial index. That's comparing the systolic blood pressure of the upper extremity versus the lower extremity to investigate the likelihood of peripheral artery disease. So the systolic ankle pressure over the systolic arm pressure gives us that ratio. And that ratio is called the ankle brachial index. Here are our norms. So our norms are between 0.9 and 1.1. That's normal. And then the lower the number, the less blood flow that it likely is having. So 0.7 to 0.9, mild to moderate. Conservative methods will probably help. This wound will probably heal, just might take a long time. We got to be really careful. 0.5 to 0.7, moderate. Patient likely has intermittent claudication. Trial of conservative methods, but some sort of surgery, revascularization surgery is in the mix. It's in the possibilities. Less than 0.5, wound healing is unlikely. Now, this person's definitely a surgical candidate, potentially limb threatening, and then less than 0.3 is you're an amputation candidate now at this point. So again, this isn't something that I would expect on to perform as a physical task, but it is a test that you need to know the norms for and what it would likely mean for that patient. Because if you're reading in the chart, the patient has no wounds, but they're a diabetic with peripheral vascular disease and their ABI is 0.5. Now your conversation with the patient is 100% prevention of a wound. We are examining footwear. We're talking about staying away from space heaters. Guess who loves space heaters? Diabetics with poor blood supply because they're cold, right? And guess where the space heaters are when they're sitting down in their recliner? Right on top of them. Guess what's going to happen? They're going to get a burn either from contact of that space heater or it's just creating so much heat right on them that they're going to get a burn just from being that close to the heat source and they can't feel it. So that is where this stuff can be really important for us. Now, this feels like a brain dump thing for me. You guys did, I think most of you did brain dumps for the lab values for the last exam. This feels like a brain dump thing for me. Just blank numbers. What does it mean? Here's this number. Here's this definition. That's what it feels like to me. Maybe it's not. Maybe you sit next to somebody smart. That was a good one. You didn't give me anything there. I mean, I don't have to study. I'm a brain dump. I'm just gonna sit next to Brent. My study's good. What's your study habit? Sit as close to Brent during the exam as possible. That's my study habit. That's how I got through. That's how I got through grad school. Sit next to smart people. All right, so we've got a couple of tests. That we get to use to help measure the blood supply. Venous refill time. Can I have the patient supine? We'll use your table, Carlos. I don't know. We've got a foot I can borrow on this table. Anybody have? Yeah, perfect. Can you take off your shoe and sock? What's that? No, perfect. Okay. All right. So first step, patient supine and relax. If you're trying to give him a pillow. First step, and this is actually the number one mistake I see in drag stools and pounds. Getting this step. First step, observe what the book looks like. Observing color, we're observing the superficial vein size and prominence. Get that snapshot of what does this. Number one mistake made on this test. Forgetting to take the shoe and talk about it. It's not, I don't know why, but it's definitely. All right, so I'm observing all of, maybe there's a lot of swelling, maybe not. I'm getting what is the baseline appearance for? Next step. We're gonna hold his leg elevated 60 degrees for 1 to 2 minutes. Again. This is the hip test? No, that's not that. I'm not testing hamstrings here. If he needs to bend this on the side for patient comfort, that is perfectly fine. What I'm going to do, elevate, how do I know I'm at 60 degrees? I could use a goniometer if I had to, right? We haven't learned it yet, but we could. 90 degrees is straight up. Halfway, right about there, 45. So I'm gonna get, it's fairly steep. This is roughly 60 degrees. All right, then I hold it up here. 1 to 2 minutes. That's the weekend with the weather, with the game, great, last game, future game, whatever you want to talk All right, after 1 to 2 minutes, what I want to do is quickly lower the patient's leg off the table into a dependent position. I'm then going to record how much time it takes to get to the normal appearance. Okay? All right, so to do that, we need to explain to our patient what we're gonna do. We need to help them. We wanna do this safely but quickly. If the safely and quickly, which one should I hear more about? Great answer. Like, so if we got, 90-year-old that has balance problems, I'd rather have an imperfect test, an imperfect data collection, but a safe patient. Now, if that happens, where in my SOAP note would I write that? In my assessment section, I would write, because of patient mobility, venous refill time took a lot of time to move from supine to seated, therefore test might not be accurate. Great, we're still gonna do it, but we just gotta be careful on how we interpret that data. Right, everybody understand the silver thing, right? All right, so from here, we're gonna sit up. Down, up, bend, great. Now I'm gonna start my timer, 1, 2, I'm looking at the clock, I've got my clock in my hand, whatever equipment I need to. I'm looking and timing to see when does this foot return to its baseline. See how I made state of contact the entire time there, right? So I can do both at the same time, because what's the risk of supine to see? Dizziness, especially if they have walk condition. Orthostatic hypotension, man, I am. I'm doing it right. That's, by the way. That's what we do is weird. Things that like it didn't even dawn on me to not say. I just get bothered. So, all right. For this test, normal is between 5 and 15 seconds. Greater than 20 seconds, it takes a long time for the blood to return, which vascular anatomy is the problem. Sure. Arteries, because we're not bringing the blood is not returning. Right, because what happens to all the blood in his foot when I elevate his foot for 1 to 2 minutes? It's all drained away, right? Good. All right, and now it's sluggish to return. What if it returns to its normal appearance in less than 5 seconds? The blood never left, which means what vascular anatomy is the problem? Venous is the problem, right? We do that for 2 minutes, we sit them up, and we go, I don't think it changed at all. Did you, by the way, notice the difference? You see how it changed that? Yeah, pretty crazy, right? Normal, healthy, and when I teach this test, there's always someone going, you can't know when it, like, that's not a test, that's not a weight, there's not a measure, there's not a ruler, you'll be able to see. So if it happens less than 5 seconds, it means blood never drained in the first place, despite it being elevated for 2 minutes, blood never drained in the first place. Big problem there. All right, let's take some time and get some quick reps on this. I think the textbook knowledge is the norms time and understanding greater than 20-second, artery less than 5 venous. I think the physical is getting up safe. That there's going to be some. Okay. All right. Let's look at some feet.
That was more.
Where's Rex Ryan when you need, right? Easy enough. Anybody forget to take the shoe and sock off first? I'm telling you, during the practical exam, someone's gonna do that. How many people didn't set up their environment so they could keep their eye on the patient and the clock at the same time? So if I'm, the back clock's on both sides, but over here, and there wasn't, I can't see it, the lights are in the way, I need to be able to keep my eye on the patient, their foot, and the clock all at the same time. One, because this test requires us looking at the foot. Two, the safety. I don't want to turn my back on my patient because when they're going to fall if I do that. Like it's the one time you do it, the patient's going to end up on the ground. You're going to hear a thud. You're going to know what that sound was. You're going to think like, I really hope that was something not that. Nope, she's on the floor. Okay. Yep. I thought so. So, I think in week one, I talked about your first step is to set up your environment. We talked about setting up your environment by moving nightstands and changing bed heights. Setting up your environment is also where is my clock? Where am I going to be? The chair needs to be here. Like all of that stuff matters too. All right, so I'm just going to blast through there's one last topic for us. We've already covered this wound care stuff, removing the dressing, measuring the wound, length, width, and depth if able, treating the wound, debriding or applying medication, then applying new. So we already did that lab. That was our brains aren't working, but let's just do this anyway. We'll get some more reps on that as well today. I want to expand a little bit more on how do we debride, what would we use as a PTA, and also other things. So we could use different electrical stimulation. We're going to learn all of those next semester. We have about a third of the course is how do we use modalities to promote tissue healing. There's some really fascinating stuff we could do. And that's one of the reasons why PT and PTAs are involved. This is slide 28. That's what you're looking for. And that's one of the reasons why there's a big role for physical therapy, whether it's PT or PTA, involved in wound care, because we can apply these modalities. It's within our licenses, it's within our practice act. Nurses cannot, even though they are experts in wound care in other ways, nurses can't do these other things. So there is a role, if you are interested in wound care, there is a role as a PTA for you to be involved in wound care. Whirlpool, again, we'll expand more on that in PTA 2. I think if you've ever been in an athletic training room, that's the whirlpool, right? Submerge your limb or the whole body in a whirlpool, turn on the jet. What do you think that does? If we've got one of those foot wounds, proximal, just proximal to the medial malleolus, what wound am I talking about? Venous. If we have a venous insufficiency wound, we put that foot in a whirlpool, we turn on the jets. Why would that be good for wound healing? So the temperature of the water itself could bring in more blood supply. That might be something we want to do. Maybe not with the venous insufficiency. Maybe others we would count for. But yeah.
I mean, I'm just throwing something
Yeah.
out there. There's companies like World doesn't like a tornado.
I'm not sure that would be the.
I'm just thinking like it helps with.
You're close. All right, so you're getting close. So the current of the water will remove some of the dead tissue that we want removed. So it's the movement of the water is helping to breathe the wound. There could be something missed. Low frequency ultrasound delivered by saline mist. Never seen it. Looked at it in textbook. I said, that's pretty cool. Okay. Put in that pretty cool. Maybe we'll see that at some point in our careers. The thing you will definitely see is called pulsatile lavage. So pulsatile lavage, this is the O'Sullivan textbook. That's the phys agents book that we will definitely use for next semester. Did anybody buy it this semester? A couple of people did. So this is in there if you didn't, if you did buy it. If you didn't buy it, I don't think you'll need it. If you do, let me know and we'll make photocopies if you need. So pulsatile lavage with suction, abbreviated PLWS, also known as forceful irrigation. So all it is a little water jet, like a water pick kind of a thing. and it cleans and debrides the wound. We just spray it. It's got little tents and usually little like plastic that goes around it to keep it all there. The suction piece, it's nice because I mean we're spraying water in a wound, so it can get messy quick. So some of those systems also have a suction to remove all of that wastewater as well. The nice thing about it, less water than a whirlpool, less support staff needed. No lifeguards on duty. The cleanup time for a whirlpool, like if you're gonna put a wound in a whirlpool tub, you have to clean the heck out of it next. So there's a lot of labor that goes involved with that. If that's what the patient needs, we're glad to do it, but that is a cost. Less treatment time. I think the number one benefit, all of those are important. The number one benefit is the patient can stay in bed. We can bring this to them. We can perform at bedside, especially if we know how to use it well. We know where to put towels. We know how to use the suction and it works. We can perform it with the patient never getting out of bed. The whirlpool, they have to transport to where the whirlpool is, and then they have to position themselves to either get in and out of it or they're limited. Like there's a lot of mobility that's required that most people that have wounds that need this level of care, what do you think of their mobility? Broadly speaking, a big problem. So pulsatile lavage is a really good option and definitely something that you as a PTA will be doing if you're involved in the wound care. So disadvantages, risk of overuse. So non-selective wound debridement, including wet to dry dressings we talked about, pulsatile lavage, whirlpool. We're going to get some dead tissue, but we're also going to get some granulation and maybe some epithelialization tissue as well. So some of the good tissue we want, we're going to be taking that away. So that's a disadvantage. Risk of new trauma from the water pressure itself, maybe the suction itself, maybe with the tips of the tools come in contact with the skin, creating it. So we have a risk there. There is a skill and a risk there. Treatment might be painful to the patient, might alleviate pain with arterial insufficiency. But PPE is required to use. We're in full splash precautions now at this point. Indications. Oh wait, O'Sullivan was the really big textbook. Here it is the phys agents book. Indications: wound healing by second intention. So we don't need to do this with primary intention. Just everything's close together in primary. Second intention. Okay, we got to clean this out. Stable flaps or grafts. That in a second. Stage 3 and 4 chronic ulcers, less than 50% necrotic tissue. Greater than that, we need a much more aggressive debridement. Precautions: healing wounds with granulation tissue. Again, we're going to take a lot of tissue off. If there's a lot of good tissue, maybe we just wait till tomorrow and just check this out again. Maybe we don't have to do it. There could be, we could use different additives in the water. Different bacterial additives. Maybe if the patient has sensitivity or allergies to those, that could be a problem. Seizure disorder it is a pulse. So if there's a seizure disorder, we could be triggering seizures. That's okay, not great. Precautions: healing wounds with granulation tissue. Oh, I just read that. Sorry. Contraindications: skin grafts less than 5 days old for split thickness or 10 days old for full thickness. We don't want mechanical force on the new surgery because that will be ruining what we just did. So leave it alone. Temperature 92 to 96 degrees Fahrenheit or no greater than 1 degree warmer than skin temperature. So that is something we could be looking at. And especially, what do you think the danger is for temperature with this? When we're talking about our patients with poor wound healing, they're here because the wound's not healing. I wouldn't be worried about infection too much. Burns. If it's the water's too hot and I'm not careful, I can actually burned my patient. Something we will talk about next semester all the time. The number one injury from physical therapy are burns. How many our techs, how many hot packs we use a day? A lot. Every single hot pack we place on a patient, they are at risk for burns. How many people, when you work first thing in the morning, how do those hot packs feel? How about at the end of the day? Less so, right? So, how many people wear bulky sweatshirt to PT and just don't feel a lot of the heat? How many people the next visit have a really thin shirt? We think like, oh, they tolerated this well, right? I don't have to worry about it. So number one malpractice reason for a lawsuit against a PT or PTA is because of a burn. One, because of frequency in which we have opportunities to burn our patients. But two, not only do hot packs burn people, we have a bunch of other thermal things that will burn patients, including this pulsatile lavage. There's also could be electrical burns. We talked about adding electrical current to heal wounds. Anytime we're adding electrical current, we have a risk of burning our patients. So we have to be careful with that. So knowing what the acceptable temperatures are is one thing. And then actually knowing and measuring what the temperature of the water you're using on them is the next thing, the actual execution of that. Duration, 10 to 20 minutes. Not bad. Pretty good. Fun for about 1 minute, torture for about the next 9 to 19. But hey, that's all right. I can suck it up for 10 to 20. The force of pulsatile lavage is 14 to 12 psi is most commonly used. So I read this in the textbook and I went a little crazy. I went down a very big rabbit hole, came out of it a few hours later. For comparison, most kitchen faucets range between 25 and 30 psi. So you go wash your hands in these things, somewhere between 25 and 30 psi. Jesus, that's not a ton, is it? Garden hoses, most 40 to 60, could be up to 80 psi. Fire hose, 300 psi. The original Super Soaker, 40 psi. And most importantly, the world record. This is what took me. So the first like 20 minutes was all that other data. Then the next 4 hours of my life was, I need to know more about this world record Super Soaker that has 2,400 psi, because we are going to blast some wounds with this thing. And that's what it looks like. That's the pulsatile lavage. And this is the world record Super Soaker, which I think add that to the list of things we learned about today. Witch stairs, Super Soakers. All right, there's our important stuff to review. So let's do this. Let's take a 15-minute break. When we get back, it's probably going to take us probably 45 minutes to an hour to get the reps of our wound care steps done. I want to get some more reps with that. So sterile techniques, doffing wound stuff, then donning all the wound stuff. As you're doing this, that step right before you apply the medication, just think to yourself, okay, pulsatile lavage, what would I do? Just based on the notes that we have. We can show you the devices. I think we have a couple of them. But just pause, and that just gives you a study rep. That just gives you a hands-on study rep. That's all we're doing. All right, so let's take 15 minutes. When you come back, let's get reps of wound dressing, okay?